there will be only one presentation in this session. The next one will be moved to after the lunch. But it's now my great pleasure to introduce to you for this session Dr. Fatem Mofta. She will have two topics during this workshop. Today she will talk about plasma fractionation, the current situation in the African continent. Dr. Fatem, who I really have had the pleasure to meet for the first time in person today, although we have done a lot of work together over the years. She's Executive Director of the Egyptian Society of Blood Services and currently President of the African Society of Blood Transfusion. She also has some consultancy and expertise work for the Swiss Red Cross, WHO, and ISBT. Dr. Fatem, the floor is yours.
Good morning, dear colleagues and friends. Thank you very much, especially for Dr. Hind for inviting me to this very important webinar, and for her colleagues to include me with this very reputable, highly experienced speakers. Today, in my capacity as the president of the Africa Society of Blood Transfusion, I'm going to touch very lightly on the current situation of plasma fractionation in the African continent. As you can see, Africa includes 54 countries, and according to the society, it is divided into 5 regions. The North region, or the Maghreb region, the East region, or mostly the Anglophone countries, the West region, or mostly the Francophone countries, the South region, and the Central region. You can see here the 5 regions are color-coded. There are some general facts about the situation in Africa. I'm going to just highlight some of them. A functioning healthcare system requires safe blood and blood products, including PGMPs, to meet therapeutic needs of patients. Low and medium income countries are suffering from the lack of PGMPs because of high cost of importation. Plasma produced locally must be qualified to meet the industrial GMP prerequisites to be candidate for plasma fractionation. Globally, plasma recovered from whole blood donations are partly used clinically and partly manufactured to PGMPs, but mainly wasted, especially in the low and medium income countries. Some facts, in particular in Africa: a large percentage of human plasma separated from whole blood donation is wasted due to several reasons. Lack of appropriate standards and technology to ensure the required freezing and cold storage conditions, lack of functional traceability of donors, lack of proper testing to lower the residual viral risk, lack of regulatory control by national authorities, and lack of quality systems and good manufacturing practice. The facts in this slide, I have gathered them from previous presentations of some colleagues in our continent during last year's webinars. In Rwanda, they are still wasting 95% of the recovered plasma, and this figure was obtained in 2021, which amounts to 20,500 liters. They have to spend $21,000 to incinerate this wasted plasma. What a waste. In Senegal, massive amounts of plasma separated from whole blood but not needed for transfusion clinically are discarded as a medical waste for lack of suitability for industrial fractionation. And as well, they need lots of financial resources to get rid of it. In Namibia, they wasted in the past up to 77% of the recovered plasma. In the past, because now they have a successful model, which I'm going to mention later during this presentation. In the recent report of WHO Afro region that was in 2022, Dr. André Loy mentioned that scarce and critical resource of plasma is currently discarded, and he assumed that more than 1 million liters of plasma is discarded. In fact, I can even think or assume that it is even more than 1 million liters, because in the same report, he mentioned that in the Afro region, they collect almost 5 million units of whole blood. And we still have the North Africa, except of Algeria, which belongs already to Afro region, but the other North African countries belong to IMRO region. They also collect maybe like 3 million units altogether. So I guess we in Africa even waste more than 1 million units or 1 million liters of plasma. I'm going today to include the countries that have or used to have or they are planning to have in the future any activity of plasma fractionation. And these countries are Egypt, Tunisia, Morocco, Senegal, Namibia, South Africa, Rwanda, Ethiopia, Uganda, and Zambia. So I'm going to start with Egypt. Egypt has gone through 4 eras of this activity. The pioneer fractionation that was in the past, contract fractionation again in the past. Currently, the mini pool fractionation, and of course I assume that it will continue in the future. And then there is also currently a plan for plasma fractionation in the very near future. So the first era was started in 1970s by Vaxera. Vaxera is the national institution for vaccines and sera. Vaxera was instructed by the national security to produce plasma products for the use in the borders in the case of war. Small factory was founded in the grounds of Vaxera and processed from 5,000 to 10,000 liters of plasma per year. The products at that time was human albumin, 5 and 15%, intramuscular immunoglobulins, 16%, intravenous immunoglobulins, 5%, and small pool of coagulation factors in the lyophilized form. Vaxera continued to produce until late 2001. The factory then was outdated and closed. Small-scale production for crude factor 8 started in the blood bank facility, the blood bank that belongs to Vaxera. And they produced actually a very nice product at that time, and it was very popular, very cheap, and very effective for hemophilia cases. And this product was crude factor 8. Which stopped in 2009. And I myself have used this for the hemophilia cases that used to come to the National Blood Center for getting transfusion. It was very effective and very affordable. And you can see that for like 3 decades, Egypt was the only fractionator in the continent, but stopped. The second era also in the past, in the early 2000s, Vaxera approached several firms to process the stored recovered plasma through contract fractionation or toll fractionation. The first trial was with RAS in China. Second trial was with Biotest in Germany. Both failed due to incomplete plasma master file and also improperly packaged samples for testing. Of course, this batch of plasma was discarded. The third trial with SK in South Korea, where they really learned their lesson and they stored some more huge bulk of plasma with complete master file and with properly packaged samples. So the third trial with South Korea succeeded when plasma master file was completed. 1 chimp only was processed. A political conflict led to the non-use in Egypt. But South Korea, or SK, the company, purchased the product which was used outside Egypt abroad. And in fact, that's also another lesson that we have to learn. Sometimes, not for any scientific or clinical reason, a very good product and highly needed is wasted or cannot be used in the same country because of some political local conflict around this particular batch, which included that we have to retest it when it came back from this company, and somebody said that we have to use the ELISA testing for the finished product, which of course cannot be. So to cut a long story short, it wasn't unfortunately used in Egypt but used in other countries. Toll fractionation stopped after this shipment due to local conflicts, and there was a lot of plasma ready to be done, but it wasn't. The third era, which started still currently in Egypt, and it will be there for some time in the future. The mini-pool fractionation. Mini-pool fractionation technology started in Egypt, and the reason for improving the utilization of domestic recovered plasma by mini-pool plasma fractionation in blood bank setup. It was applied in Egypt since 2013 and helped to produce more than 50 million units of factor 8 at 50% reduced cost of the similar imported product. 2 facilities are currently doing this mini-pool fractionation. One in the private sector and the other one in a large university hospital in Asyut in the southern part of the country. And it is worth telling how this technology started in Egypt around 2005. It started by imagination of 3 eminent people, 2 from Egypt and 1 from France. The one from France is Dr. Thierry Bournouf, who was supposed to be with us, and he's not here. Dr. Magdi Al-Ikiabi and Dr. Hadi Gobran, who is a hematologist. The 3 of them were discussing why, at that time, many of the fractionators globally were either closing down or merging together. And the main reason was because of the large amount of plasma needed to start a cost-effective industry. And it was like a dream or like a joke. Dr. Hadi Gobran said, why don't we do like the Japanese people? When they made a dwarf trees for the very beautiful trees to decorate their homes, which is like the baby of a big tree. So he said, why don't we have, instead of huge plant, we have all these steps done in a small kit and in a blood bank setup. It started from there. And these 3 people worked for like 5 to 6 years on a prototype of this technology, which was later patented, and it was purchased by a Swiss company who took it further to the present form. This technology uses CE-marked medical devices and chemicals produced and marketed by a Swiss company for processing fresh frozen plasma in small pools between 4 to 7 liters in one disposable kit to produce several products as follows: factor 8, Von Willebrand factor, fibrinogen, factor 13, IVIG, solvent detergent FFP. This is a diagram that shows the disposable kits, and it is made of polymer. Another diagram. And this is a picture that shows some of the finished product. Now I'm going to talk about the 4th era for the future in Egypt. There is a joint project between military and Ministry of Health from the Egyptian side. The plasma collection centers were already established in several governorates. Plasma is collected and stored according to GMP requirements. Fractionation plant is planned to be constructed with Grifols in Spain. Contract fractionation is decided with Grifols till the completion of the plant and till the know-how transfer is in place. And this company is called Grifols Egypt. Now I'm moving to Tunisia. And I'm Dr. Salam Ahmeda, after me, is going to elaborate more, but I'm going to just say very little about it. In the past, military blood services in Tunisia had contract fractionation with Pasteur Institute in France to produce blood albumin, which stopped in 1995. They processed about 6,000 liters per year from 20,000 donations. Later on, Ministry of Health National Blood Transfusion Center had a contract fractionation with LFB in France between 1999 until 2002. The products were limited to albumin and IVIG. This activity was licensed by the National Regulatory Authority in Tunis. And this graph shows the amount of the two products that were produced during the 3 years. The information and the slide is care of Professor Kamel Boukeif. I'm going to move to Morocco. Yes. In Morocco, there is a contract fractionation with LFB in France, and it was in the beginning signed in 1999, and the signature was renewed in 2012, and the activity is still going on until today. There is a huge commitment by the Moroccan Blood Services of full quality system covering from the donation to the transfusion process. And these are prerequisite by LFB to qualify their plasma for industry. 2 centers in the beginning were accredited, followed by 2 more centers in 2012, and I believe there are 3 more accredited to be included in the future. Moroccan regulatory framework in general is compatible with the EU regulatory framework. There are always regular assessment, annual or maybe more than 1 time per year, regular assessment and external audits by LFB to the Moroccan transfusion centers that are engaged in this activity to make sure that it is always committed to the GMP steps. Only recovered plasma from voluntary non-remunerated blood donors is exported to LFB. An average of 6,100 to 6,500 liters per year. All testing kits are CE marked. There is a strict cold chain activity to make sure that it is also quality plasma. Yearly, around 30,000 packages of different PGMPs are exported back to Morocco from their local national plasma. This amount of packages saves more than 55% of the local Moroccan needs. The PGMPs, which are produced in France and come back to Morocco from their national plasma, are human albumin, 20 and 4%, human coagulation factor 8, human coagulation factor 9, normal immunoglobulin intravenous, 5 grams and 10 grams packages. The plasma is transported in refrigerated trucks and then by the boat that is heading from Casablanca to Paris. The Central National Blood Bank keeps the temperature records during transportation of plasma from regional blood banks to the center before exporting it to Paris. And this information and slides were care of Dr. Khadija Lahjouji from Morocco. I move now to Senegal. The idea started by a report or guidelines from WHO to advance progress towards the goal of improving access to safe plasma protein products. ISBT approached WHO with a request to host a collaborative effort to conduct pilot projects for local plasma protein product production. The National Blood Transfusion Center in Dakar was approached to establish local preparation of pathogen-reduced cryoprecipitate through education and on-site support. Recovered plasma is targeted. Pilot project is currently supported by the Swiss company, which is the mini pool fractionation, and the company's name is VIPS. To explore this feasibility in sub-Saharan Africa under the supervision of ISBT and WHO. And it already started like 3 years ago. In order to fulfill this project and realize this project, Senegal had several objectives to stick to. First, situation analysis, then capacity building on good manufacturing practices for blood establishments, Then technology transfer and validation for preparation of pathogen-reduced cryoprecipitate. The next objective is capacity building on assessment criteria for the national blood regulators. Then informing of the patients with inherited bleeding disorders. Then training of the treating physicians. Finally, communicating with blood and plasma donors. And this information I got from Professor Salou Diop in Senegal. After that, we go to South Africa. The South African National Blood Services, which is, we call it SAMS, collects approximately 950,000 units of whole blood donations annually, almost close to 1 million. Excess plasma is sold to National Bioproducts Institute, NBI, for the manufacture of plasma-derived medicinal products. SAMS implemented a source plasma as well, apheresis, to increase more and more the bulk of plasma that is processed by NBI. And this program from voluntary non-remunerated donors. Blood groups A and AB donors were targeted more since they have an excess supply of whole blood donations. NBI, or National Bioproducts Institute in South Africa, was established in 1994 and is the largest biotechnology pharmaceutical company in South Africa. It was registered as a non-profit company. It is self-funded and non-government entity. Manufacture biopharmaceutical products from human plasma into PDMPs. NBI develops and manufactures diagnostic kits as well, and monoclonal antibodies for the South African and international diagnostic market. NBI, they have their products registered with South African Health Products Regulatory Authority, or SAPRA. NBI sells PDMPs in several sub-Saharan African countries and monoclonal antibodies sold in India, China, USA, France, and Australia. The company itself, or the factory itself, is based in Pinetown, South Africa, which is approximately 20 kilometers from Durban. And here is the building of the headquarters of NBI, and the products that is produced are fresh-dried plasma, immunoglobulins, albumin solutions, coagulation factors, diagnostic products. Why did South Africa succeed in this model or in this business? The blood services in South Africa focused on main areas like regulatory framework with national standards, sufficient blood collection, stringent cold chain, state-of-the-art donations testing, blood processing into components and appropriate storage, functional laboratory information management system, quality system, and traceability. I got this information from Dr. Jehan Omarjee from NBI. There are, of course, benefits from this very successful model. The benefits, one of them, a group of them called fractionator value-added services. So South African blood services really benefit from drug information center, from education and training, from support for patient programs by NBI. And of course, there is an economic benefits also to the country, including employment. Blood services receives revenue for the plasma, retention and development of scarce skills, resource optimization, contribution to the budget. And indeed, NBI is the only fractionator in the African continent at the moment. Now I move to Namibia. Namibia had collaboration with NBI in South Africa since 2013. The recovered plasma was stored for 5 years, starting from 2018, and was shipped very recently in 2022 to NBI. Supply of surplus plasma, which is around 77%, previously discarded, it used to be discarded, and they now exported it to NBI. This plasma is obtained from 100% voluntary non-remunerated blood donations, 84% of it from repeat donors. This is very impressive, in fact, in Namibia. Centralized testing for the whole country. So only one laboratory tests for the whole country the donations. And the drive for this cooperation is the need for more income to fund NAT-ID testing, and also the need for PDMPs to treat local patients. So this is a very legitimate drive. The size of plasma recovered during these 5 years is more than 33,000 liters. And before the cooperation, toll fractionation started. High cost of discarding unused plasma was part of this decision, because they used to spend a lot of money to get rid of this plasma, and that was part of the decision to have this cooperation. And in fact, as Senegal or Namibia or Rwanda declared that they used to spend money to incinerate this unused plasma, there are other countries that I know for a fact that they don't spend this money, but they used to get rid of this plasma in a very hazardous way, like pouring it down the sink, and this is very hazardous. But unfortunately, it happens in some countries. This activity is a perfect example of a win-win situation. And this model was very inspiring to other countries. This information, I got it from Mr. Israel Shipari in Namibia. Now I move to Rwanda. Yes. In 2022 February, MBI assessed the blood transfusion department for the potential processing of their recovered plasma. MBI asked for some requests to be fulfilled by the blood services in Rwanda before they come again and do further assessment to prepare for, again, toll fractionation. So these requests were blast freezers, NAT testing, update software, enhanced cold chain and blood processing, and update the Africa Society for Blood Transfusion accreditation. In fact, Rwanda, they have the Step 3 accreditation, and they are doing very well, but they need to update this accreditation in 2 years. And Rwanda is now really progressing in these requisites or prerequisites to be eligible very soon for exporting their plasma. MOH agreed to go ahead for the toll fractionation project. And this information I got from Dr. Thomas Miombo. There are other countries that MBI themselves approached so that they maximize the outsource of the plasma. MBI assessed the blood donation to transfusion chain as preparation of outsourcing plasma from more African countries. All prerequisite steps were done, like self-assessment in the beginning, then physical assessment by MBI, and they do this at least 2 times, and then they ask for some requirements, as I mentioned, and they wait for these requirements to be fulfilled. And sometimes, by the way, MBI contribute in these requirements, like, for example, supplying NAT testing equipment and reagents. These countries are Uganda, Ethiopia, Zambia, Tanzania, and Senegal. This is part of the project, which is called Plasma from Africa to Africans. Ethiopia now is ready to go ahead after the approval of Ministry of Health. Now, these are the only countries that have anything to do with plasma activity, plasma fractionation activity. But I have some recommendations for the rest of the continent. Like establishing systems to ensure quality and safe blood products, maximizing component preparation and usage, according to the infrastructure of the blood transfusion service and the needs of specific country. And I like to concentrate in this meaning, because some countries, they tend to just copy models from other countries under peer pressure. And this is a trap that sometimes costs them money without any benefit actually. So every country should know what are their needs and what suits them, because some countries, they don't have the basic means to diagnose and the basic needs to treat. So why follow blindly some other country that they can treat, they can diagnose and treat? I mean, I have seen it in some African countries. It's either peer pressure from neighboring countries or either peer pressure, not peer pressure, but industrial pressure by some companies who would like to sell their products. So it's very important that countries should really study what do they need for their own infrastructure. To continue on my recommendations, also standardization of the collection, transport, production, testing, and storage of the donations. Staffing infrastructure required to prepare quality blood components. Supporting the local production of quality plasma collected locally from voluntary, non-remunerated whole blood and source plasma donors. Namibia model is very successful. Improving access to essential medicines and to safer blood products, as well as ensuring self-sufficiency. Now, I'd like to thank you very much, and perhaps at the end of the day, we can have questions. Thank you.
Thank you, Faten, for this very inspiring lecture. We will move on very swiftly because we have now time for the second presentation of this session. It will be presented by Dr. Slama Hamida from Tunisia. And the topic is the challenges that led to the failure of plasma derivatives manufacture in Tunisia. Dr. Slama is a professor in hematology of biology and general director of NBTC in Tunisia. So I will not make a longer presentation, but leave the floor to you, At
the beginning, I want to thank all the organizers for their kind invitation, and Dr. Hind especially. The team of that give me to treat is plasma fractionation, Tunisian experience, and obstacle that block the manufacturing process. The plan of my intervention, I will give an overview about health sector in Tunisia, transfusion organization in Tunisia, blood donation, and plasma surplus. After that, I speak about Tunisian experience in plasma fractionation, what have been done, other attempts to manufacture plasma derivatives, and the difficulty encountered. After that, I will ask to the question, what are the obstacles that led to the failure of the manufacture of plasma derivatives in Tunisia, and conclusion. Tunisia is a country of 12 million inhabitants. We can find 22 establishments. Donc, Tunisia is a country of 12 million inhabitants, 22 establishments of public health, 34 regional hospitals. We found 21,600 hospital beds, 4 faculties of medicine, 1 faculty of pharmacy, and faculty of dentistry. Transfusion organization in Tunisia is organized. Transfusion in Tunisia is organized by law of March 1922. This law defines conditions for blood collection. Human blood is collected in Tunisia for free, with consent of donor, and paid donor is not authorized. This law defines also distribution criteria of blood and condition for use. Here we have the flow chart of transfusion in Tunisia. We found
Next.
we found flow chart of transfusion in Tunisia. The transfusion is represented in Ministry of Health. We found central unit of transfusion and the blood banks. Under that, we found National Blood Transfusion Center with 5 regional transfusion centers, when 2 are academic and 3 are non-academic. We found also military center dependent of Ministry of Defense. We found also 26 blood banks in the hospital, and this blood bank depends of direction of hospital and not depend of NBTC. We found also in this flow chart National Immunology Technical. Blood donation and plasma surplus in Tunisia. About 228,000 of units are collected in 2022 throughout the territory. About 68% are family donors and 32% are voluntary donors. Here we reported 3 centers involved in plasma fractionation, the NBTC with 2 regional centers from SFAX and SUS. In NBTC, we collected about 76,000 units, in SFAX about 30,000 units, and in SUS about 20,000 units. The surplus of plasma in the 3 university centers are estimated about 40 units of plasma. The volume plasma surplus is estimated at approximately 6,000 to 8,000 liters by years. Plasma preparation, what conditions that are met? In Tunisia Transfusion Center, plasma preparation comply with the condition of acceptance of plasma by LFB. The LFB have audited the 3 centers involved in plasma fractionation. Audit concern all processes related to the plasma production, collection whole blood plasma, testing, processing, and quality control, and quality assurance and information system. The referential used is Tunisian legislation and good French transfusion practices. Plasma fractionation, what have been done in Tunisia. 3 experiences of fractionation have been performed. 1997, fractionation of 4,000 liters of plasma. 1999, fractionation of 2,000 liters of plasma. And 2001, fractionation of 3 units plasma of liter of plasma. The 3 experiences concerned plasma type 3, concerned only plasma from NBTC, allowed the production of albumin and immunoglobulin. If we see here the cost of operation, the cost to buy the same quantity of product, and the bank interest and the margin of PCT, Pharmacie Centrale Tunisia, we see here there is no amount generated for this operation. And we can say this operation is unprofitable if we take into account the mass of work behind this operation. The same for the experience of 1999. There is no amount generated for NBTC. Despite that, the financial return is low. Both operations covered 50% of albumin need for Tunisia and some percent of immunoglobulin needs. We have considered this operation valorize of our plasma. Other attempts to subcontracting of plasma. Attempts of 2008, in 22 April and 23 April, two audit by LFB for Regional Transfusion Center for SUS and SFAX. All the parameters of the operation of fractionation have been showed. Planned quantity to fractionation was 3,000 liters. Expected date of shipment 1 September 2008. The contract focused on plasma type 1 and preparation of albumin, polyglobulin, polyvalent immunoglobulin, factor 8, factor 9, and factor Willebrand. If we see the plan of this operation, we can see the total price for the SIP treatment is about £1.5 million, and total price to call for tender is about 2.6. This operation is winning and can win to the NBTC about $1 million. Unfortunately, this operation was not successful. The main reason of that, the director of Tunisia Central Pharmacy did not agree to sign the subcontracting. He said, contract contains technical clause. I cannot commit to the technical aspect. Attempts with catering company from Italy. In 2018, we contacted the catering company to see the possibility to subcontracting of plasma. The answer was positive. Pre-assessment contact have been launched, and evaluation audit in the three centers of Tunis, Sfax, and SUS have been scheduled. Before to start audit, Kedrion has required to sign of the letter of intent. 6 November 2018, I have addressed the letter to the Ministry of Health. We have requested to authorize me to sign the letter of intent. Proposed to set up, and I propose to set up a commission within the ministry to finalize I propose to set up a commission with the ministry to finalize the project and study the financial of subcontracting. April 19, answer from Ministry of Health, request the opinion of Personal Data Protection Committee, Ethic Committee, and request a technical file from supplier. August 19, technical and administrative files have been sent to the General Director of the Health, no response till date. March 22, reminder letter to the General Director of the Health, no response so far. The question, and the answer to the question in summary, what are the obstacles that led to the failure of the manufacture of plasma derivatives in Tunisia? Obstacle linked to the local manufacture of plasma derivatives. In this context, 2 projects at Maghreb scale had been proposed without success. Main reason, lack of profitability, very small quantity of plasma. Obstacle to subcontracting of plasma. Lack of management flexibility, ministry approval is needed. Lack of cash of financial dependence of the NBTC. The obligation to go through the central pharmacy which has the legal monopoly of the importation of drugs. Heaviness of bureaucratic procedure. In conclusion, since many years a lot of plasma is discarded, a significant global plasma shortage, the lack of means in medium and low income countries, and the administrative burden constitute an obstacle to the subcontracting plasma fractionation. We have a great hope in the project initiated by our colleague in Arabia Saudi. And thank you.
Thank you so much, Dr. Slama Mida. And I think we will save the questions for the later sessions and the panel discussion tonight. It was very interesting to hear about the typical problems you can encounter in a country when you try to set up your system for a good plasma strategy. So we give the applause and we will await for the opening ceremony next. Thank you very much.